Hello, thank you for the opportunity to talk to you. My name is Abhishek Chandan Kandai, and I'm an assistant professor of psychiatry at the University of Illinois at Chicago. I'm going to talk briefly today about thinking outside the box, using integrated care models to improve mental health care. Mental illness and addictions affects millions of people worldwide and is a leading cause of disability and lost productivity. Shortages of funding and psychiatrists have forced us to rethink how we take care of mental illness and think of creative ways to incorporate or integrate mental health treatment into general or primary care. Studies show that few patients with mental illness get the care they need. In the United States, 60% of adults never get connected with mental health care. 20% go to their general doctor or PCP, and only 20% even get to see a psychiatrist. Traditional referral models are by and large ineffective. Traditionally, patients are referred by their general doctors to psychiatrists. However, studies show that half of all patients do not even complete the referral. Of that half of patients who actually see a psychiatrist, the average number of visits is only 2, so it's not a long-term relationship. In general, there's not enough time for a current psychiatrist to see all patients in the United States. Some people ask if current psychiatrists could just see more patients. In the US, ideally, a psychiatrist would have 50 minutes to see a new patient. But to see everyone who needs to see a psychiatrist, in US cities, psychiatrists need to do that same amount of work in 6 minutes. In rural areas, psychiatrists can only spend 1.5 minutes. So obviously, current systems are not working to serve the mental health needs of society. Thus, we move into models of integrated care. By integrated care, I mean healthcare models where psychiatry and mental health are incorporated into the primary care setting. On this slide, you can see examples of different healthcare models with increasing levels of integration. Over the next few slides, I will give a brief introduction to these models of care, ending with collaborative care, a complex but very effective model found at the University of Washington in Seattle. First, we start with the traditional referral model we're all familiar with. In this model, the general doctor identifies a mental health need in a patient, then sends them to see a psychiatrist somewhere else. While this model is the simplest, there is minimal communication and collaboration, and it is difficult to coordinate care. Many patients simply get lost in the system. Remember, at least half of all referrals simply do not happen. Next, we go to a remote consultation. In this model, the general doctor identifies a mental health need in a patient and talks or emails with a psychiatrist located elsewhere about a specific question they have. My person is depressed, do I start a medication? My person's having a lot of anxiety, how can I help them? It's easy for the patient, they don't have to go anywhere else, and gives access to an expert to general doctors, while saving time for the psychiatrist to do a full appointment with a patient. However, it's usually one time only and requires extra work for the general doctor. In the medical center model, the general doctor and psychiatrist are located within the same hospital or medical complex. This is more integrated as doctors will often share the same medical record, making information easier to find. There's less duplication of services and easier access for patients. However, patients may refuse to go to a psychiatry clinic due to stigma, and there's usually no direct communication between doctors, even within the same medical center. In the co-location model, the general doctor and psychiatrist are located in the same clinic. In addition to sharing a medical record, the doctors are located in the physical same space, so it's much easier for patients to see a psychiatrist. They don't have to go to a separate clinic, they can just go down the hallway. It's also easier for general doctors and psychiatrists to have ongoing conversations about patient care. However, this still does not solve the problem of not having enough psychiatrists, and schedules can fill up quickly for psychiatrists in the co-located model. In the patient-centered medical home model, the general doctor leads a care team of doctors, including psychiatrists and other healthcare workers, all in the same clinic to provide comprehensive care for the patient. There are care team meetings, coordination, and increased access for patients. High risk or high needs patients are quickly identified and helped, and the care team can look at entire groups or populations of patients to look at larger needs. However, Care is still mostly done patient by patient, which does not solve the problem of too many patients, not enough time. All of these models lead now into the collaborative care model, first developed in the 1990s at the University of Washington in Seattle. This model built and expanded on prior integrated care models and is recognized as the most researched, efficient, and effective model for integrated care in mental health. So how does it work? Briefly, a patient comes to see their general doctor, and the doctor is concerned for depression. This is confirmed on routine screening with a standardized tool, such as the PHQ-9. The general doctor then discusses the case in person, a process called a warm handoff, with a care manager located in the same clinic. A care manager is a nurse or community worker trained in mental health who serves as a care coordinator and go-between for the general doctor and psychiatrist. Once a week, the care manager then discusses this patient and other cases with a consulting psychiatrist for recommendations on medications and other care. These recommendations are finally relayed back to the general doctor, who can then directly treat the patient. The 5 principles of collaborative care are connected principles. 1 is patient-centered collaboration. 2 is population-based care. 3 is evidence-based care. 4 is measurement-based treatment to target. And 5 is accountable care. Over the next few slides, we will discuss these principles more. With patient-centered collaboration, we see that the general doctor, the psychiatrist, the care manager all work together to serve the patient in the middle. The patient stays in the same clinic, and the care manager serves as the main point of contact for mental health needs. With population-based care, every patient in the clinic with mental health needs is placed on a registry or database managed by the care manager. Each row on this spreadsheet has a patient, the first depression and anxiety scores and most recent depression and anxiety scores. The care manager is responsible for updating this registry frequently and making sure nobody is forgotten. This registry is then discussed weekly with the psychiatrist, and the most ill patients are given priority to keep improving the overall population's mental health. With evidence-based care, the system only uses medications and therapies that have proven evidence to work for patients. In this model, the care manager is trained in simple therapies like problem-solving therapy and cognitive behavioral therapy that can be standardized. Also, only medications that fit the patient's needs and are supported by research are used. This helps make treatment both efficient and effective. With measurement-based treatment to target, the system regularly checks how patients are doing by frequent use of scales that measure depression and anxiety, such as the PHQ-9 and GAD-7. Rather than trying to judge globally whether people look better, patients are treated until the depression and anxiety scores are below a certain threshold and stay low for a set period of time. This helps make treatment goals more objective. Lastly, with accountable care, the system undergoes regular evaluations, for example, annually, with doctors, psychiatrists, and care managers looking at the data and seeing what works and doesn't work. Focus is given to how the population is doing from a mental health perspective, how patients are experiencing the care provided, and how much it is saving costs. Regular quality review keeps the system accountable and continuously improving. Now, I understand that this is the most complex of the integrated care models, the collaborative care model, but decades of research show that this is the most efficient and effective of the integrated care models we have. An early major study, the IMPACT trial in 2002, showed across many clinics across several US states that collaborative care, compared to usual treatment by referral, led to twice as many patients improving in their depression. Collaborative care also leads to more patients overall receiving depression treatment, greater satisfaction with mental health care, lower depression severity, lower functional impairment in daily tasks, and greater quality of life. There is broad evidence for collaborative care. Uh, Since the IMPACT trial, there have been over 80 trials showing the effectiveness of the collaborative care model, from children to pregnant women to elderly patients, and for many conditions, including anxiety, PTSD, chronic pain, addictions, bipolar disorder, and schizophrenia. More generally, integrated care, including the collaborative care model, has been studied in countries around the world and found to be effective. Here's a map of just some of the countries where integrated care models have been studied in mental health. And you can see it includes low, medium, and high income countries across all of the inhabited continents. However, there are challenges to keep in mind when doing integrated care, and especially the collaborative care model. First, all people involved, general doctors, psychiatrists, nurses, community workers, have to believe or buy into these new models. Also, when trying to find a care manager, do you hire a new care manager or use existing workers and retrain them? It can also be hard to think about the population as a whole instead of patient by patient as we're used to doing as physicians, and keep the registry frequently updated so patients don't get lost. We need to pick the right tool to best measure what we are trying to treat, whether it is depression, anxiety, or something else. The right evidence-based medications, therapies, and services need to be assembled to give patients the most options, and workers have to be trained in these methods. Lastly, the system has to be reviewed and improved regularly, otherwise we get lazy and things start falling apart. This brings us to the end of the talk. For further information on integrated care, especially the collaborative care model, please visit the AIMS Center, which developed this model at aims.uw.edu. The American Psychiatric Association also has a great website describing these new models of care at the below link. Thank you all very much for having me for this talk. It is a great honor. A special thank you to my department chair, Dr. Anand Kumar, and our global health director, Dr. Stephen Winey. Also, special thank you to my colleagues at the UW AIMS Center who helped me with this talk, Dr. Raman Tour and Dr. Amrita Bhatt. Please feel free to email whenever. Now, let's take some time for questions and discussion.